Thank you, everyone, and thank you also specifically to Dr. Delpria for giving me the opportunity to talk today. I've been providing menopause care for patients for over 12 years, and it's been a fight to have any attention for women's health. And so for someone to come and ask me to speak about menopause and mature women's health is such an honor. So I just want to, thank you very much. So as a menopause specialist, not only do I care about your ovaries, I also care about your hearts, your breasts, and your bone health. And so we have 15 minutes together. I'm only going to touch the surface of the information that I want to share. Usually when I present, it's primarily women, but today we have a mix of men and women, which is amazing because for those of you who are not born with ovaries, I'm sure you love somebody who does. And so I'm hoping that this can provide you some education also about how to support your partners, your siblings, or your parent, or even a child. How do I do this? Sorry. There we go. So here are my objectives. I want to really clarify what menopause is. And recently one of my colleagues in Vancouver has changed it from menopause to menoadolescence. Because really this is a time where women have an opportunity to find themselves again after years of suffering through all of their periods. We're going to talk about what women go through today as Generation X women. I'm going to walk you through the precision medicine of menopause, the personalized assessment that we do in my clinic every day, the MQ6 digital tool that is available online, as well as what I do in conducting a risk assessment for every woman that I see in my office. And finally, if I have time, I'm going to show and share with you a couple of patient cases. So what is menopause? Where do I aim it? There we go. Okay, so menopause is a universal experience, meaning that if we are fortunate to live long enough, every one of us will experience menopause at some point in our lives. It is essentially because of a loss of follicular ovarian function. So what that means is that as women, we are born with about 7 million eggs in our ovaries when we are actually a fetus inside of our mom's tummy. And when we are born, we have about 300 to 400,000 eggs in our ovaries. When we hit puberty, it comes down to about half. And by the time we hit menopause, and for every woman it's a little bit different, it's down to about 1,000. So as a woman, we go through about 300 to 400 ovulations in one lifetime, and the other hundreds of thousands of eggs in the ovaries are lost just through natural aging and wear and tear. The average age that a woman goes into menopause globally is 51 to 52, but it can happen anywhere between the age of 45 and 55, and the hallmark of the diagnosis is really a loss of periods for 12 months consecutively. If a woman has had a hysterectomy where her uterus has been removed, but her ovaries are still in place, or if she has a Mirena IUS, which is a progesterone-containing IUD inside the uterus, which stops periods, or if she's had an endometrial ablation, she may not be able to use her period as a marker of her menopause, but the general woman otherwise would use her period to determine that. Now, it's also important to know that there are a group of women who go through menopause early, and that is, there's two classes of women. One is premature menopause, when it happens under the age of 40, of which there are 1 in 100 women. And then there are also women who go into menopause between 40 and 45, and that's called early menopause. This class of women have to be treated differently than women who go through menopause at the average age, because these women have long-term consequences for their health in terms of heart disease, early onset osteoporosis, and dementia, as well as worsening genitourinary symptoms. So these women need to be referred to a specialist right away to start hormone therapy if they don't have contraindications to prevent long-term consequences of the early menopause. Why does this happen? Dr. Kapoor talked about the word idiopathic, which basically means that the majority of time we actually don't know. It can be sometimes due to family history, but also for women who may have had a surgery where they had their ovaries removed, either because of something wrong on the ovary, or potentially because they have a BRCA1 or 2 mutation, and they're removing their ovaries to prevent ovarian cancer. It also can happen after chemotherapy or radiation from some sort of a malignancy. And for women who have their ovaries removed, it can be very drastic and very severe. So we really want to ensure that we address these women and ensure that we support them through their menopause experience. Sorry, I think I'm just missing a slide here. Do I point this here? Where do I point this thing? Oh, this way. I've gone too far. How do I go back? Okay, so we've talked about what menopause is. What is perimenopause? Perimenopause is generally a new term for a lot of women, and this is the 4 to 7 years leading up to that final menstrual period where women can experience a whole slew of symptoms where it can present with period changes as well as a lot of mental, sleep, and mood changes as well. So we'll talk a little bit about that in a second. This is a time where women often are the most symptomatic and are getting the least amount of help. So if you are a woman or have somebody that you love who's going through this, it's important that you advocate for yourself and ask for help, because the majority of women, even today, are still not getting the help they need in their perimenopause. And so what is postmenopause? Postmenopause is from that last period and for the rest of your life. And for women who are now living into their 80s, we're spending 30 to 40% of our life in menopause, which means that this is an important time of our life where we need to be looking at what we can do to ensure longevity, both in terms of our health span that we've talked about, and how to minimize the risk of chronic medical conditions. And really, it's only been in the last 100 years that women are outliving their ovaries, because only in the 1900s were women still actually living or passing away at the same time as menopause. So menopause is no longer considered an end-of-life event or where you are past your prime. This is really a midlife event. Menopause can be very liberating for many women. We don't need to worry about periods. We don't need to worry about pads and tampons anymore. We don't need to worry about getting pregnant. It is also a time for women where they tell me that they feel a renewed confidence and they've rediscovered their new potential. And for women whose children have left the home, sometimes it can also improve intimacy and relationships with their partners as well. So I want women to not think of menopause as a scary time of life, but that this is really an opportunity to make yourself and your health a priority, and that you deserve to do that. So what are the symptoms of menopause? Well, there are over 30 of them. And what I want women to know is that you actually have estrogen receptors throughout your entire body, starting from your brain all the way down to your toes. So in our brains, we have estrogen receptors that can lead to hot flushes and night sweats, brain fog, concentration difficulties, mood changes, and sleep disturbances. We can also experience changes in our skin, in our hair, in terms of hydration, thickness, and growing of those substances. We also have a lot of women who tell me that there's a change in their weight, cardiometabolic changes where there's an increase in visceral fat, so more abdominal girth that they notice during the menopause transition. There's also a new condition now called the musculoskeletal syndrome of menopause, which was only coined in July of 2024 this year, which really identifies the changes that happen in the joints and in the muscles and in our bones as we age. And so women may present to their family doctor having new joint pains or arthralgias or arthritis, where we do imaging and find nothing, and then the patient is told there's nothing wrong with you. But this is actually because of a drop in estrogen levels, and we as women need to be able to understand and advocate for ourselves to get the help that we need. And the majority of these symptoms actually do get better with time. The only thing that does not get better with time is the genitourinary symptoms, which we call genitourinary syndrome of menopause. And this is presented because we also have estrogen receptors in our bladder, our vulva, vagina, and urethra. And so women will start experiencing urgency and frequency. There may also be waking up in the middle of the night to use the bathroom, more bladder infections, more pain with intercourse, and a lot of dryness. I've heard it feels like sandpaper or razor blades. These are things that are really significant, and we need to address this for patients. So what do we do? What are women actually experiencing today? So the problem with menopause care in 2024 is that for the last 20 years, there have been all the physicians and all the medical doctors who have graduated have had zero education in menopause care because of a study that was released in 2002 that told us that hormone therapy is dangerous because it causes stroke, heart attack, and breast cancer. But the problem with that study is that there were women between the ages of 50 and 79, which is a 30-year age difference, and they clumped all of those events all into one. But what they've now realized is that there's actually a window of opportunity that for women who are under the age of 60 or within 10 years of their final period, hormone therapy actually is considered safe, and for the majority of women, the benefits outweigh the risks. And so understanding that is important when you are considering whether to accept treatment. 1 in 2 women today completely feel alone in the menopause transition, and 4 in 10 women feel alone. Even though family doctors are still their most trusted source of health education, only a quarter of women actually tell me that their patients even bring this up to them in their family practices. What about menopause and work? The Menopause Foundation of Canada actually released a report last year called Menopause and Work in Canada. And what they've come to realize is that there are so many women who are suffering through their menopausal symptoms at work, where about 1 in 10 women will actually leave her workforce because of unmanaged symptoms, and that leads to about a $3.5 billion of lost income annually in Canada because of women who are not able to continue to work when they are at the prime of their careers. Hot flushes are the most common symptom that women experience. 80% of women experience this, and it can last for 7.5 years. So this is not something where you just need to wash your hands and say it'll get better. This is actually very long that women suffer, and so accessing care is extremely important. Women are still hot flushing about 40% in their 60s and 10 to 15% in their 70s. The other thing also is that for women who have the most severe and frequent hot flushes, it's actually a biomarker of cardiovascular disease because we see the highest amount of plaque in their carotid arteries. So that also is something to be aware of. When it comes to what to do about your menopause experience, the most important thing that you need to know is that there is a lot of misinformation out there today. Because of the vulnerabilities of women who are trying to access care and cannot seek a menopause specialist because there's so few of us in the country, there are a lot of providers and services that are trying to sell products to patients or services that are very expensive that may not be based on evidence. So really we want to be critical of the information that we're accessing. And so I'm just sharing a few resources with you: the Canadian Menopause Society, the Menopause Foundation of Canada, Aging Powerfully with Melissa Grello is an amazing podcast, and the nq6.ca website. Internationally, the Menopause Society has a lot of information, as well as the International Menopause Society, and they have specific links for women that are very easy to understand and follow. So what do we do in terms of assessing a patient? So the nq6.ca is a digital tool that you can access as a patient as well as a healthcare provider on nq6.ca. And it's a very simple tool where we're asking 6 simple questions to patients to be able to determine the impact of our menopause journey. So has there been changes in your periods? Are you experiencing any hot flushes? Is there any vaginal dryness or urinary symptoms or sexual changes? How is your sleep and how is your mood? And I do go through every single one of these questions with my patients at each appointment. And then on the nq6.ca website, there's actually a free algorithm for both patients as well as for healthcare providers that kind of walks you through what you could potentially do to manage your symptoms. And it's an interactive and free algorithm. So as a menopause expert, what I do is an individualized risk assessment where I look at not only her symptoms, but what is her risk factors in terms of her heart health, breast health, and bone health. And then together we come up with a therapeutic plan that not only is going to treat her symptoms, but also improve her quality of life and improve her ability to continue to function on a day-to-day basis. And so in terms of what the recommendations are across the world, Canadian, North American, and the International Menopause Society, menopausal hormone therapy is still considered the first-line treatment for bothersome hot flushes and night sweats, more so than any non-hormonal therapies, which I think the majority of women are still getting prescribed. But remember, not one size fits all. So there may be patients who have contraindications to hormone therapy, or they may have the desire not to use hormone therapy, or there may be other risk factors that we need to consider. And so every individual woman deserves to have an individualized assessment to ensure she's getting the right help that she needs. Now I have a couple of cases here, but I think I've run out of time. So am I allowed to go over for 5 minutes? Okay, not. If one case, okay. So this is Miss Hot Flash. She's let me just go back here. She's 48 years old. She's a realtor. She's perimenopausal. Her last period was 6 months ago. She has 3 children. She's divorced, but has found a new relationship. And her husband has had a vasectomy. Her new partner has a vasectomy. She's a non-smoker, and she does only drink 1 drink of alcohol per week. 3 months ago, she started having a lot of hot flashes, both during the day as well as at night. She's waking up at night with night sweats. She feels very irritable first thing in the morning. She's very short-tempered with her kids. She feels bad about her temperament. She cannot remember her client's phone number, so that verbal memory recall is really beginning to bother her. She's worried about her future memory and dementia risk. And she's also worried about her future earning potential because she feels like she cannot keep up with her work demands. The big thing that you want to know in terms of her history is that her mother had breast cancer at the age of 55, and she also has very dense breasts. Now, some patients think that having a family history of breast cancer is a contraindication to hormone therapy, and that is not true, but your breast density has a significant impact on risk of breast cancer, even more than family history. So women who do not understand the benefits of a mammogram by age 40, it's imperative that as we do a risk assessment for you in terms of treating your menopausal symptoms, that you actually have a breast mammogram and ultrasound to determine what your breast density is. So these are the things I consider when I'm doing a risk assessment. Do you have any contraindications? How old are you? Are you perimenopausal or menopausal? Do you still need contraception? What is your heart health risk? What is your breast cancer risk? And then I also talk about what her personal preferences are as well. So here are the contraindications to hormone therapy, which is very small. So a personal history of breast cancer, a personal history of stroke, heart attack, a blood clot both in your lung or in your legs, any undiagnosed vaginal bleeding, or suspected pregnancy, which means for women who have diabetes, high cholesterol, high blood pressure, obesity, or even migraines, hormone therapy is not contraindicated. So I'll stop here after this slide, but this is just a slide that emphasizes what the breast density information is about. So on the left-hand side, you can see breasts which are more dark, and on the right-hand side, you can see breasts which are more white. And on the very bottom, you can see a scoring of A, B, C, or D. And what that represents is your breast density, which can only be determined on a mammogram. You cannot feel for this. You don't know it based on your breast size or inconsistency in the 2 breast sizes. Why this is important is because a malignancy is actually white on a mammogram. And so if you have dense breasts, it can more easily be missed. And the other thing is, that you can see here in the blue lines, is that the more dense your breasts are, the higher the relative risk of breast cancer. Now, hormone therapy does increase breast cancer risk, but it is very nominal, 1 to 2 women per 1,000 after 5 years of use. And so there are forms of hormone therapy that we can actually use that does not increase breast proliferation. And a lot of healthcare providers are unaware. So that one in particular is called Duaviv. So Duaviv is a combination of an estrogen and a selective estrogen receptor modulator, which actually decreases breast density. And so when you are doing a risk assessment, what I'm trying to highlight to you is that we have a toolbox of hormone therapies, and the toolbox is like makeup brushes. We have to individualize the treatment to each individual based on her individual risk factors, her symptoms, her age, and what her future hopes are. So thank you, and I'm sorry I took more time than I was supposed to. I appreciate your attention.